back, so we've had a fantastic day so far, learning about how we can collectively keep people safe within the ambulance sector. So my name is Joe Leary and I'm from Echo Fire and Medical. It's a little bit obvious today. And I'm here to talk to you a little bit about safe recruitment and how we can together look at the sexual safety within the ambulance sector. And part of that today is looking at a micro study that I was involved in, where there was somebody that was working in the ambulance sector that perhaps shouldn't be. And we'll expand on that shortly. Next slide, please. So the ambulance sector is made up of various different organisations, from NHS Ambulance Service Trust to CQC registered organisations such as ourselves, and then the non-regulated sector. So these are your event first aid sectors, they are the TV set medics and so on. Next slide, please. Now, we all have a wider responsibility for safeguarding in general. We also have one with regards to our recruitment processing. Now, when we take people on to work within the ambulance sector, we're looking at a wide range and a holistic recruitment cycle. That can be from safeguarding through to DBS status, through to the rights to work in the UK, and also the qualifications that we all in the wider sector have to work within the scope of practice within your organisation. Now, Health and Social Care Act of 2008, Schedule 3 specifically, does state that the Health and Social Care Act of 2008 in respect of persons employed or appointed for the purposes of regulated activity. So I've mentioned a moment ago that we have a network of unregulated providers providing the same sort of services that we do within a non-regulated sector, and there is still that risk of those individuals there carrying out some form of sexual harassment or exploitation, whom then may go on to work in a regulated provider, and due to the unregulated activities previously conducted, they might not be we might not be exposed to that information. So what does this mean for the private sector and the NHS ambulance services? Do we look at the authenticity of background checks? So that's the non-regulated providers. What is the authenticity there? What quality of references and background conducting are we carrying out as part of those recruitment cycles? So we're also going to talk about the enhanced DBS and disclosure service and how this affects your risk level within the recruitment sector. Do we rely on it too much as a private provider, or do we include that as part of a holistic approach to our recruitment process? Next slide, please. So we all have our own recruitment processes within the sector, and that will be backed up by all your clinical governance policies, your recruitment, the right to work policies and processes within your organisation. To list a couple of them and to briefly run through some, we've got comprehensive application packs. So what does your application pack want to achieve? What are you looking for? What information are you trying to obtain to make sure that you're, first of all, putting patients first, and secondly, recruiting the right person within the genre to work at what we do? The background checks, personal and work related. So would a spouse or a friend be an authentic reference? Would a non-regulated provider such as a first aid event medical company, what would be the authenticity of that reference? The rights to work within the UK or the sector specifically today. Driving licence checks, assessments, skills, qualifications, evidence and assessments within their scope of practice, declarations and agreements, contracts, registration checks, NMC, GMC and HCPC. Plus we've had a little look today at the HVAC. Disclosures, risk mitigation, review process and the who, the when and the why. So who will carry out this recruitment process? Who will look at the reviews? Who will look at the DBS disclosures and make a barbless referral to the eDBS platform? When will this be done and why? Why are you doing this? What is the risk that you've identified within your organisation or within an individual to make that sort of referral? Next slide, please. So I'm going to talk today about a micro case that I was involved in, where there was an individual that was working within the health and social care sector, and in particular the private ambulance sector, whom, although recruitment processes were adhered to and Schedule 3 was maintained and adopted, and good practice was seen within the organisation, that this individual was still able to work with those most vulnerable. So within the private healthcare sector, we do see an increased risk of individuals slipping through the net, so to speak, and I'll expand on that shortly. So for many reasons, we need to be looking within the health and social care sector, just within the ambulance services too. This for many reasons, but my belief is the ease. So how easy is it for these individuals to go from provider to provider within the private sector specifically and be untraceable, or concerns that have been raised previously that haven't been identified and passed on due to the regulated, non-regulated divide, and also the the smaller companies that are unable to have those, or should have, but don't always have those more robust reporting processes in place. So in 2021, this year, I was part of an investigation process which did look into the risks surrounding an individual who did obtain a position within a healthcare sector, and in particular private ambulance service. And this individual had no convictions on their DBS. So I'm going to talk about this particular case today. They had no convictions listed. They were clear of barred list checks for the adult and the vulnerable children sector. The individual did have some concerns within the free text noted by a police force relating to, and in the wider context of this individual's background, a low-level incident, which the police service felt it was something that a recruitment process should pick up on in the future. This particular free text that was included on this DBS was risk mitigated. It included regular reviews and it included a risk assessment for that individual based on the free text that was available on that DBS. Next slide, please. So this individual was open about the content that was on their DBS. Now, within some organisations, the openness and the transparency of what was on the DBS with written reflections and statements about what happened is a reassuring thing to see. But we don't always get the bits that aren't on the DBS. And it was hard to hide the fact that this was on there because it was printed. So the individual naturally did expand upon what was included there. A short time later, some information came to light surrounding the individual, and with it, there was a focus drawn to their rights to work within this sector. An investigation was launched, and I was part of that investigation. And the individual was questioned surrounding the information that was brought forward. So remember, this is information that wasn't on the DBS with no convictions. The recruitment process for this individual was inspected by senior managers of staff within the organisation. The CQC, the local authority designated officer, and the health and social care sector in wider context was all involved in looking at different organisations that were involved within this individual. It was found that the organisation did do everything correct with regards to risk mitigation based upon the information that was submitted and brought forward, including the information given by the applicant upon their recruitment process. The enhanced DBS system, the pre-employment checks were all correct, they were all there. Throughout, it was demonstrated that the compliance with Schedule 3, particular about this individual, was there. So what was the problem? And why did this, or how did this individual obtain employment within the health and social care setting? Next slide, please. This individual failed to disclose multiple serious allegations of historical sexual assault as part of their application process. My belief is that this is because it wasn't listed on the DBS, and we'll come to why and how that wasn't listed on there later. Next slide, please. The individual had not been charged with anything, remember, so there was nothing listed in convictions or any cautions in any sort of way, even though there were multiple assault investigations carried out previously by police forces, but there were no cases to answer, and this person had been tried and released without charge. Casting back to the comments and free text section that was listed upon this DBS, the individual did have a note placed within the comments section, which I've just mentioned, and in the wider context of these serious allegations of sexual assault, this was quite minor, but still risk mitigated. There was no notes relating to the assault cases in any part of the DBS. Now, the concerns were raised about the individual's suitability to work with vulnerable people and vulnerable groups within the healthcare setting, but also the staff members too, not just the patients that we serve. This brought a very difficult and complex situation forward with a few questions to be asked. So why were there no notes relating to these serious allegations despite no convictions? Bearing in mind we did get some notes from a particular police force about a rather minor situation that was not related. In relation to the above, why was a minor investigation listed but the wider context large ones weren't? And with no conviction, how can we mitigate risks for patients and the vulnerable people that we come into contact with if an enhanced DBS comes back in this situation relatively clear? Next slide, please. So this individual was subsequently dismissed for reasons which included failure to disclose personal information relating to their background, and the provider liaised with the police forces, the local authority, the CQC and ambulance service trusts to ensure that full transparency was adopted throughout what is a very difficult and complex situation, and that patient safety was without question maintained, not just for this case but for the future cases too. So together that we can learn something from this. And as a result, I wanted to bring this micro study forward. Next slide, please. So I've got a bit of a question here, really, for us all to think about when we go way back to our organisations and back to the companies we run, own and work within, the organisations that have HR and recruitment and background checks that are carried out, the safeguarding teams and leads. Do we rely on the enhanced disclosure too much within our selection process, or particularly in the private sector? Or is this just simply a piece of a holistic recruitment cycle? So I have seen on social media, and I have seen within the event forums and things where people advertise lots of different types of work available to clinicians and non-clinicians across the country. And it's very, on a regular basis, very last minute. So for example, somebody needs a medic tomorrow in Southampton or London or something. All we need to see is a DBS and a certificate. But what about those underpinning checks? What about that enhanced check and that holistic approach to looking at the essential 3 requirements that we have and the obligation to work within them, but also the authenticity of the background checks carried out for the people that we have representing us and going to the same people that need the same help, whether it's an NHS ambulance, a regulated provider's ambulance, or a non-regulated provider that is sending a medic or paramedic or technician or ECA to attend to that patient. Next slide, please. So we need to look at risk mitigation. So comprehensive application documents. What is your process? Do you have a flow chart for this? And is it easily identifiable and understandable to people should you not be working in the office on the days that this recruitment process takes place? Interviews. What sort of questions are you asking? What we're going to ask about the sexual background and the safety and the enhanced DBSs and the rights to work and any conduct issues that's been previously risen. Regular monitoring for staff. The authenticity of references, which I've mentioned. So looking at a private, a regulated, non-regulated provider, a friend or family member, is the person that's making the reference part of an organisation that they work for, that they co-own, for example? How will you mitigate risk and comply with your Schedule 3 requirements to keep patients safe? Next slide, please. So we need to think about a few things here, and if we just pop up the rest of the slide, I'll just run through them collectively. So we need to look at the who. So who will be responsible for monitoring new starters activity? So who's going to do that? We're going to look at a line manager. We're looking at a recruitment process. So we're looking at the peer assessing feedback, etc. What forms part of your information gathering with regards to their conduct and their professional approach to patients? When will this be done? So when will you carry out the reviews of performance and the reviews of the risk as well? So we've had some comments within the questions section that look at all organisations working towards, or the comments relating to the anticipation for organisations to work towards all staff being on the online update service check, so we can carry out real-time and more regular EDBS checks. So when will this be done? 6 monthly, biannually? Why are we doing this? What we're wanting to achieve? We're looking at complying with Schedule 3. We're looking at keeping people safe. We're looking at making sure that we're delivering the services that we do as NHS organisations, as private healthcare professionals and freelance medical staff to ensure that we're complying with Schedule 3, but we're also raising the concerns, we're also risk mitigating, and we're also making the right referrals to the DBS platform. Next slide, please. So I want to finish this really with sort of saying today that we've talked about a micro study or a little case that I was involved in here. We looked at the holistic cycle of recruitment, and although the organisation did the things that were right and that the information brought forward was relatively clear, there were statements and there was references. There were enhanced DBSs on the update service, may I add. There were references obtained from previous employers, from character reference individuals, application processes, but a particular individual did make the way into the public domain wearing green. So although we can do the very best that we can do, or the best that you've already been doing so far, it is still evidence that there's a risk out there and that people still can slip through the net. And it's about how we can work together, have the right information passed between the organisations, utilise the enhanced DBS disclosure barring service referral system, and together create a more safer working environment for our staff and for the patients that we attend to. Thank you.
Thank you, Joe. Good morning, everybody. My name is Anna Price and I'm the named professional for safeguarding from the East of England Ambulance Service, and I'm here to present about learning as an organisation from Operation Elkins. Please can I have the next slide. So Operation Elkins was the name given by Cambridgeshire Police following the arrest and subsequent custodial sentence of Andrew Wheeler, who was an ex-paramedic here in East of England, who was jailed in February 2021 for sexual assaults against patients whilst working for East of England. So the whole context of this morning's fantastic presentations, this is the consequence if things are slipping through the net. So a serious incident for the whole organisation. I've put the biggest safeguarding case in for East, but actually if we look at it, it's probably the biggest safeguarding case of its kind for the whole of the UK ambulance services. And I akin this to a really bad road traffic accident. Everybody wants to have a little look, but it's really difficult to talk about or discuss, but it's here and it's real. Next slide, please. It's also really worth noting before I move on, we're talking about a male here against female, but actually males and females all perpetrate abuse. So as an organisation, what have we done? So huge external overview from the CQC, the CCG, European Commissions of Human Rights, how we are working as an organisation to put this right, to make sure it doesn't happen again, and also to share the story. So for other organisations, both NHS and voluntary and private, learn from us. So we have just a list here that we're doing at the moment. We have weekly updates given. We have a monthly meeting with our exec director who have safeguarding in their portfolio. We have an integrated improvement plan in place working together with the CQC. And within the organisation, it's cross-working with other departments as well. It's really important not to silo work. Next slide, please. So we've looked at policies and procedures, and as it was noted in the CQC presentation, that's one of the biggest things. We've got an allegations against staff. Policy, we asked our critical friends from the CCG and NHS E&I to also help us with these. It's about having external advice from our excellent counterparts that can help with these. We ask for feedback actively, so from our LADO cases, we have a feedback form. We've received some back, and that's really helpful for learning, and it's also helpful with being transparent. And one of the really best things that we've introduced as an organisation is we have a daily golden hour call. We have access to 2 directors between 4 and 5 every day. So if we have early concerns or risks that are taking place, we can have 2 directors on a call to help navigate those really, really complex decisions. Next slide, please. So we've risk assessed all of our allegation management cases for employee relation cases as well as safeguarding. And as I said before, we have 2 directors, especially if we're discussing suspension calls. It's really good to have a check and challenge to have different directors on the call. Ensuring welfare is in place, that's a really, really huge thing. And we follow through all of our safeguarding cases, no compromise agreements if you resign, retire, or leave before the end of an investigation. Next slide, please. So one of the really key things that we've done and we'd like to promote is for our level 3 intercollegiate document training, we are using external providers. So for those of you that don't know, Zoe Roderick is a psychotherapist. She's fantastic, and she's come in to do some psychology of offender management training and some trauma-informed care training. Because we talk about our patients and how they are at risk, but actually our staff are as well, and hurt people. So how trauma-informed is our training for safeguarding for our staff? They're the people that deliver the care to our patients. So how do we discourage this behaviour? So Zoe presented to our trust board in March of this year, and we've been successful in rolling out the training to our staff cohorts. Next slide, please. So as I said before, we've just decided that our level 3 training for this year is to be all around abuse of position and trust. This would meet the requirements from our intercollegiate document and also learning from Operation Elkins. Next slide, please. So For the first year, we've opted for some modules to meet your level 3 safeguarding requirements. So we have got psychology and offender management by Zoe and trauma-informed care. Super important. We also look after staff that go through allegations made. Not all of the time are they founded. As DCI Brown mentioned, the police deliver abusive position of trust training, which is really welcomed here. We have a lot of people with good questions, because actually some people think that inappropriate sexual banter isn't even criminal, but actually the police will explain what it is and what it can lead to. I present some allegation against staff training. We have Health Education England, safeguarding training for adults, and our local partnership boards for our children. So this is what our first year level 3 modular training will look like. Next slide, please. So what else? So good multidisciplinary training. We need our managers, our junior managers, our interim managers, our seconded managers to look at what behaviours, what's the signs and symptoms. Is being late for work an issue? Is being insubordinate an issue? Absolutely, it's all risk-taking behaviour. And it's empowering people to speak up, use of freedom to speak up, use of whistleblowing. And all of this is monitored and reported, as we said just at the beginning of the presentation. Next slide, please. So we've got designated critical friends externally from the organisation. We've had assistance to help with some of our complex safeguarding investigations. And what I would really like to, as an organisation and as a disciplinary, as a whole, should we have external critical support at the point of our panels? What does that look like? How would that support commissioner managers and indeed chairs that are listening to complex cases that involve safeguarding? Next slide, please. So use of academia, as DCI Brown said, they use the University of Bournemouth, and as an organisation we're exploring the idea of having them come in and have a look at. We've got quite a number of reported and immediate cases of sexual predatory, so let's have a look at what academia can offer. Can we explore offender profiling, and can we predict who's seeking to work for us, and for those who are with allegation? Next slide, please. So LADO stands for Local Authority Designated Officer. Should we look at oversight of cases? Once cases are closed, should they be scrutinised? Was there learning? Was there things missed? Was it timely? Is there anything that we can learn on it? Should we look at a memorandum of understanding for oversight of opportunities and learning? We really are not able to cope with this as individuals. It needs to be collective organisations and learning. Please may I have the next slide. That was a really quick, and I can talk quick. So thank you so much for your time. I'm happy for any questions in the chat, and enjoy the rest of the presentation. And I'm going to hand over to Mr. Hayden Newton. Thank you all.
Thank you, Anna. Good morning, everybody. My name's Hayden Newton. I'm the Director of Quality and Clinical Governance from an independent ambulance provider by the name of Thames Ambulance Service Limited. Can I firstly say, as an organisation, we're delighted to be part of this webinar, and really appreciate the opportunity to get to share with you very briefly our experience of the Freedom to Speak Up Guardian. Next slide, please. What I'm going to look at on this presentation is the role of the Freedom to Speak Up Guardian and the lessons we've learned about this role, and to take you through some just 6 or 7 slides in terms of probably some advice, some areas where we've noticed that we can look to improve the effectiveness of this role within the organisation since it's been in for around about 15 months. Next slide, please. Just some background about the company. We provide only non-emergency patient transport services. We don't provide A&E support or any A&E service provision whatsoever. We have contracts and bases in the north of England, in the Midlands, and across down into the south into Essex. We have 4 registered CQC locations, and on top of that we have 12 operational ambulance bases, with the head office being based in Lincoln. Our sister company is in Spain, a company called UTG. They're the probably biggest provider on the mainland of A&E ambulance services and non-emergency ambulance services as well on the mainland of Spain. So we're the really the British arm of that organisation. Next slide, please. As I say, it was established, the Freedom to Speak Up to Guardian was established 15 months ago. The idea incidentally came from one of your colleagues, Helen, Catherine Allison, who's our CQC lead for the company. She suggested it at that time. Of course, it was a voluntary requirement for independent providers, and we've had it in place for around 15 months. It's a great role. It provides confidential advice to staff in relation to any concerns they have, works with the board to develop an open culture within the organisation, which I know in many ambulance services, either NHS or independently provided, can be quite a challenge. It's another way for staff to speak up. The thing about this approach, Freedom to Speak Up Guardian, it's a confidential service. And of course, far better than raising an incident through a normal incident reporting process, and it gives staff confidence in coming forward with any concerns they may have. It works entirely independently of the executive team, and we've got a number of Speak Up champions appointed across all of our bases. What I would say though, there's a tendency not to use the Speak Up champions. They all prefer to use the Speak Up guardians. And I think the pattern of that is confidentiality, distance, to take a local issue out of the local setting and to get some very, very good impartial and professional advice. Next slide, please. Looking at the values upheld by Freedom to Speak Up guardians from the national guidance, we've got courage, speaking truthfully and challenging appropriately, impartiality, to remain objective and unbiased, a degree of empathy, listening well and acting with a level of sensitivity, and learning, seeking and providing feedback and looking for opportunities to improve. These are what we've looked for in the appointment of our Freedom to Speak Up guardians, the 4 key principles, and to measure and to judge the success of the Freedom to Speak Up role within the company. Next slide, please. At the moment, we have one average contact per month for around 650 staff. Contact can be made by either telephone, a dedicated email address, or through face-to-face meetings off-site. We would encourage face-to-face meetings off-site where possible, not always possible in some organisations, but it does give the sense of a degree of confidentiality and a different setting of which people can feel they can talk freer and also talk easier as well. Confidentiality is respected, and the details of the case will not be shared outside the bounds of the agreement made with the individual being supported. What do I mean by that? Quite simply, some things to resolve their concerns may have to be discussed with other people within the organisation. So what our approach is for the guardian to raise that, to get approval to do that with the individual raising the concern, and then to have that discussion with the respective director, head of department, etc. Next slide, please. Lessons we've learned since the role's been in place. I say it's been around 15 months now. There's clearly a national competencies framework and job description, which is extremely helpful, and it really does set the qualities and standards required of the Freedom to Speak Up guardian. The other thing we found makes a real difference is to ensure that the guardian has a sound understanding of the business in all aspects of the business, in terms of policies, procedures, processes, and is well respected in the organisation, also has the credibility and also the strength and determination to go to talk to often very senior people in the organisation when they can share an issue or a problem which has been raised by a number of staff. Incidentally, our Freedom to Speak Up guardian is a level 4 safeguarding trained lead for TASL, very competent individual with a long length of service with working with the company. The other thing we've noticed as well is offer different ways of contacting the guardian to your staff. Dedicated email goes straight to the guardians concerned themselves. Nobody helps us visibility to that. Phone number of the guardian is shared, and we encourage looking at all other different ways of being able to make contact. I've already touched on face-to-face meetings. Staff, in our experience, prefer a face-to-face meeting off-site. Somewhere to go off-site, sit and have a cup of coffee with the guardian. I think they feel it's easier to speak, and the setting is more conducive to being able to sort their issues out and support them. The other key issue is to keep a confidential register of the contacts received, and the purpose of doing this is because obviously it's clearly confidential. We want to look to see if we're picking up any themes and trends. If there's anything within the organisation from the feedback that's come from our staff that we can look to change, to amend, to make better. Are we missing something on policies? Is there anything at all we can improve upon? Of course, that remains confidential. Again, the Guardian would develop strategies and plans from the themes and trends that she's brought in from our particular staff. So all in all, so far extremely successful. Absolutely delighted the suggestion was made and it's now in place, because anything which gives our staff the chance to contact us with any concerns they've got and to have confidence about confidentiality, impartiality and professionalism has got to be right. So thank you for your time today, and if I could hand over to John Martin, LAS, please.
Thanks, Hayden. Good morning, everybody. So my name is John Martin. I'm the Chief Paramedic and Quality Officer for the London Ambulance Service. I'm joined today by two of my colleagues, Damien McGuinness, who is Director of People and Culture, and Alan Taylor, who's our Head of Safeguarding and Prevent. So we're going to take you through two examples of good practice from the London Ambulance Service. The first is our Chaperone Policy, and the second is our staff safeguarding allegation referrals to relevant bodies. Pick these two topics because when we were filling in our questionnaire for the CQC, I said to the team, because I'm new in London Ambulance Service, what do we do that's good in relation to sexual safety? And these were the two themes that came up, and hence why we've opted to speak about them today. So just to give you some context, the London Ambulance Service serves the whole of London, which you'll find within the M25. We have a population in excess of 8.6 million. That goes up and down during the year and during the working day. We attend more than 3,000 emergency calls. That's 999 every day, treat more than 1.1 million patients that come in via that service. We're also the 111 provider for 40% of London, and the staffing that comes with that is slightly different to our 999, and we currently employ over 9,000 staff. In terms of safeguarding, last year we received just short of 25,000 referrals across our safeguarding team. We work with 32 different boroughs. That means we participate in 64 different safeguarding boards and partnerships that you can see on the slide. Oh, next slide, I should have said. And next slide again. So I should be on a government broadcast. So here you'll find the breakdown of our safeguarding overview for last year. The current team within safeguarding, headed up expertly by Alan Taylor, who's on the line if we've got any questions, consists of 11 staff. So we have safeguarding specialists, data coordination, administration, and we've recently employed a learning disability and vulnerability specialist that we're excited to have as part of our safeguarding team. If we could go to the next slide, please. So I'm going to take you through our Chaperone Policy. What you'll find on the slides is some extracts from our policies, which we're very happy to share as an organisation to support improving sexual safety across ambulance services in the United Kingdom. So we introduced our Chaperone Policy back in 2017 following the Miles Bradbury case at Cambridge University Hospitals and the subsequent NHSE guidance that was issued to trust. Our policy sets out the use of chaperones and procedures that should be in place for clinical consultations and particularly during intimate care. And it is in place to safeguard patients and employees across the whole of the London Ambulance Service. Next slide, please. So what you'll find in our policy is some definitions like you find in most policies. So we've identified what a chaperone is, what an informal chaperone is, and what a formal chaperone is. And I think that's an important distinction within ambulance services because often we end up needing to use informal chaperones because of the context in which we visit our patients. If we go to the next slide, please. So in terms of the objectives of the policy, we set it out to ensure patient safety, privacy and dignity are protected during intimate examinations procedures during the delivery of intimate clinical care interventions according to their roles, minimising the risk of clinicians' actions being misinterpreted, ensuring that staff are aware that all patients have the right to a chaperone. I think this is a really important one, and making sure that our staff are aware of the need to have that chaperone in place. And to ensure that staff are aware that the Trust policy on consent and examination and treatment must be adhered to at all times. So alongside our policy in terms of chaperone, we also have a policy on consent to examination and treatment. And in educating our staff, we make sure that they're aware of both of these policies together. Next slide, please. So in terms of the role of the chaperone, we've identified this within our policy and we've rolled this out across our staff. So it obviously varies depending on the circumstances, but it may include providing a degree of emotional support, reassurance to our patients, and it commonly incorporates providing protection to healthcare professionals. I think it's really important in the context of today's webinar. Assisting in the examination of procedure, for example, handling instruments, or assisting with undressing, dressing and positioning the patient. The nature of pre-hospital care is reliant on clinicians to have an understanding of what is required as an informal chaperone. And in terms of what we've been doing in the London Ambulance Service, we've been really emphasising this since this policy came in a few years ago. We go to the next slide, please. So in terms of principles of good practice, it's the chaperone's main responsibility to provide a safeguard for all parties, patients and practitioners. So it is there for both people involved in the examination and as a witness to continuing consent to the procedure and examination. In order to protect the patient from vulnerability and embarrassment, a chaperone should be of the same sex as the patient or the gender the patient identifies with. So we've outlined within our policy this ability that the patient can choose who the chaperone is, a really important principle. An opportunity should always be given to the patient to decline a particular person if that person is not acceptable to them for any reason. This must be recorded in the patient record form. And we know that this is sometimes difficult within the ambulance service context, but making sure that patients absolutely have the right to choose and decline. We go to the next slide. We've then outlined a bit of our principles of good practice. When these slides come around, you're very welcome to borrow this. The Trust advises the use of formal chaperone is always considered, particularly in relation to all intimate examinations, which include, and we list out here some of those areas, so unaccompanied children when examining the upper torso of a patient, etc., as those areas where we might want to consider a formal chaperone. If we go to the next slide, a particular issue which faces ambulance services is that of lone working, where a clinician is working in a situation away from other colleagues. So our first responders out on cars, family liaison officers, etc. The same principle for offering and use of chaperones should apply. So although we work within this context, we are encouraging and within this policy that clinicians should consider the need for a formal chaperone, even if they are working on their own. And that might require requesting backup. It might require requesting someone who's already on scene to partake in that role, but not using the lone working as an excuse for not considering the chaperone policy. If we go to the next slide. I think the next slide should say training. I will carry on talking, finish off the presentation. We seem to have lost some slides. So in terms of training, we have trained all of our staff in the chaperone policy. So really important as a key part of writing any policy is not that we just launch it to our staff and we circulate it across the organisation, but we also train our staff in the use of any policy. So the chaperone training has included what is meant by the formal and informal chaperone, what is meant by intimate examination, why chaperones need to be present, the rights of the patient, policy and mechanisms for raising concerns. So we have rolled this training out across the London Ambulance Service, and we've also rolled out safeguarding level 3 training and refresher training for our staff where they are where they've had that previously, to ensure that they're up to date on the chaperone policy and what it means. So that ends what we wanted to update on in terms of best practice in terms of chaperoning. I'll quickly tell you about safeguarding allegations against the staff. So the Trust has a duty to ensure that measures are in place to protect and safeguard children and adults at risk. We've written a policy specifically around what happens when we get an allegation against staff. And we've already heard in some of the presentations this morning key parts of this. So the legal duty to refer individuals to the DBS service in certain circumstances. We've aligned the policy to the Safeguarding Children's Act, as well as the Care Act 2014. So what's good in our policy? Well, we definitely focus on reporting, doing that quickly within a 48-hour period that we would have informed the NRLS, so the National Reporting Learning System, via our DATIX, and with immediate reporting once an allegation is received to convene the senior managers to make an appropriate decision on the actions that are taken. The executive lead for safeguarding is informed and they liaise, that's me, with the CQC. External reporting, so we use the head of safeguarding and prevent, and Alan Taylor holds that post within our organisation, who advises on reporting appropriately. So referral to the police, social services, child safeguarding to the LADO, and adults at risk to the LA Safeguarding Adult Manager. So we use our experts within the organisation to help us decide who should be reported to and when. And so when it comes to those referrals, in cases where it's decided it's appropriate to do so, HR do the referral and referral to the DBS. We do also refer to the Health and Care Professionals Council or other regulators, and we've heard from Grant this morning about the HPAC as well, for those who don't fall inside statutory regulation currently. Referral to alternative regulatory bodies may be necessary, and we use that as part of our policy. So our policies are available, and a lot of the wording is on the slides, which we seem to have missed out. So we're happy to share them. I'm going to finish there because I think we're at our 10 minutes, but both Damien McGuinness, our Director of People and Culture, and Alan Taylor are available for questions when we get to that bit. We can put that in the chat. So I'm going to hand over now to my colleagues Nicola and Jane from the North East Ambulance Service to hear about their good practice.
Good morning, everybody. My name's Jane Stubbings. I'm the Safeguarding Adults Lead for North East Ambulance Service. I'm joined by my colleague Nichola Howard, who is the Safeguarding Children's Lead. We've heard this morning on more than one occasion about the importance of having policies and procedures in place when it comes to managing safeguarding allegations against our staff. At NEAS, we have reviewed in the past year all of our safeguarding allegations policies and all the interlinking policies with our HR colleagues. We did that really to ensure that our systems and processes are robust, and we wanted to assure ourselves that we had a consistent approach when it comes to managing safeguarding allegations against our staff. Next slide, please. Oh, sorry, you've moved on to this slide. So when an allegation does come into the trust, we do try to have what we call a case conversation. This was part of some focused work that came out of a 10-week task and finish group. We'd always historically had internal strategy meetings when it came to safeguarding allegations against our staff, but we felt that there needed to be a more formal documented process, and we also felt that there needed to be a core membership within that group. So we devised what was called a case conversation record. So when an allegation comes into the trust, we will hold a case conversation. That meeting generally in today's world takes place via Teams. We've got really good buy-in from the core membership. It normally takes place on the day that the allegation is made. If we can't have the meeting on that particular day, then we'll do a quick risk assessment and we'll hold the meeting at the next working day. Our core membership will be somebody from our Human Resources Department, which is normally an HR business partner, one of our operational managers, normally clinical service manager, and the direct line manager of the person the allegation is made against, and they'll either be myself or Nicola from a safeguarding perspective. There has been occasions where we've had to invite other people into those case conversations. So when allegations have come in about students who are working with us, we've invited somebody from our education and training department, and we've also linked in with the university to make sure that the appropriate person's in attendance from that perspective. We will look at the source of that information. We'll look at what we know at that particular point in time, and we'll also consider any gaps within that information, because quite often what we get told is often quite limited, and we have to go off and source relevant information from different people. As part of that shared conversation, we'll look at all the risks that we can possibly identify in line with the allegation that's been made. We'll identify the risks to patients, to colleagues, to the trust, and to the person that the allegation's been made against, and all of those are documented. We will then go on to consider what that person's job role is, and we'll look at the risks we've identified to see whether or not we can feasibly keep that person at work. Can we mitigate the risk and allow them to continue to do the role that they do? If we can't do that, then we will look to an alternate duty for that person. Can we mitigate the risk that way, keep them at work doing something different? Again, if we feel that that's not appropriate, we will then look at suspension. If we do look at suspension of that particular member of staff, we'll undertake a suspension risk assessment form because we recognise that that comes with additional risks for that particular staff member. As part of the case discussion, we'll look at roles and responsibilities and actions, and we'll identify who needs to pick up what action following that meeting and the time frame for that action to be reported back on. I'll hand you over to Nichola now, and she's going to talk about our escalation processes, both internally and externally, and how we report, and also the benefits of that case conversation. Thank you.
Thank you. We could go to the next slide, please. So the use of case conversations with the NEAS are very much a coordinated approach, and what they've really shown us is they promote professional curiosity when we're faced with an allegation made against a member of our workforce, because we look not only at what we know but what we don't know. We would also look at our recruitment process, what's been declared, establish if there's been any missed opportunities, as well as their employment history and conduct previously. As we know, often within child safeguarding practice reviews and safeguarding adult reviews, there's often an emphasis placed upon the requirement to develop cultures of acceptance of professional challenge, and our case conversations are no different to this. The discussions that we have within these conversations are open and honest dialogues. They are safe spaces for senior managers to discuss and identify and look at ways that we can mitigate or manage risk, not only, as Jane has said, to our patients, but to other colleagues, to our organisation as a whole, and to the member of staff themselves. And it encourages respectful professional challenge where there may be differences of opinion, especially when we're looking at whether we can mitigate risk appropriately. And if we can't come to a conclusion in that respect, we look at our escalation process, so we can look to step that up to a more senior level. Case discussions are very much reliant on having appropriate representation from our subject matter experts and from across the organisation, such as the safeguarding leads and our knowledge and understanding of perpetrator behaviour and victim response. And that's often the reason why our investigative officers, when we look at having somebody to investigate the allegation, are drawn from the safeguarding team because of their subject knowledge expert in that field. We also have our trusted HR colleagues who are there to offer their expertise in employment legislation and also our internal HR processes. And that really ensures that we have a kind of firm understanding of the circumstance of the allegation and the management of that. As part of the recent Task and Finish group, it was identified that shared paperwork would support a more consistent and clear kind of case discussion, as well as ensuring that we don't duplicate our processes, and it ensures that we don't have any discrepancies in our documentation. This shared paperwork, as Jane has said, clearly highlights ownership of various aspects of the action plan and the timescales identified completion of these, and this really supports increased accountability and responsibility, as well as reducing the possibility of case drift when managing these cases. The paperwork also clearly identifies what has been established, explores how risks impact on our service, and clearly articulates any rationale for decision making and how we've managed those risks. If we could go on to the next slide, please. So following our case discussion, we look at our internal external escalation report and plans. So in terms of our internal escalation, all of our cases are escalated to director level if we need to have any disagreements in terms of our risk management plans. Information is also shared to our Director of Quality and Safety, that's for CQC liaison purposes, to ensure that we have openness and transparency throughout the whole kind of process. And then senior managers from the staff department are also invited to attend those case conversations to ensure that any risk management plans are consistent and are sustainable in longer terms. And as a safeguarding team, we regularly report to our trust board on a quarterly process. And then in terms of our external engagement, so we notify the CQC at our monthly engagement meetings of all of our allegations against staff, and we would do appropriate referrals to our LADOs, local authority, if these meet the criteria. We also have reporting processes to our CCG designated nurses at our strategic safeguarding meeting also, and then we would have considerations for police notification if we believe as an organisation a criminal offence has taken place. And then finally, if we look to remove a member of staff from their kind of normal roles, or we change their role slightly to mitigate risks, then we would look at referrals to their professional bodies, whether those are NMC, HCPC or GMC. And this really just helps to provide us assurance to our external partners in terms of our case management and our mitigation of risk. And that is it from us, and we are now handing back over to Liz Ratcliffe from NHS England.
Thank you so much. So it's now our chance and opportunity to kind of pull together some of the themes from this morning and some of the discussion points. I have to say it's been a really good morning, and the presenters have been excellent, so thank you so much. Also, thank you for all the questions that are in the chat box. We've had 28 published. Every one of them has had a response and reply, so that's fantastic. I'm sorry, I'm just hit, the rain has just started to pour down where I am, so it's not great from hearing point of view. So what are some of the themes that are coming out? We're talking about thinking the unthinkable. How do we protect staff, protect people who are lone working? What do we do to keep them safe, but also what do we do to keep the public safe? So there's been lots of suggestions there on how we do that. And I think when that presentation came up, referring to lone police working, I can absolutely say that this happens in health as well, because we have lots of lone working in the health sector, and there's lots of documented evidence where people have been in positions of trust and found to be guilty of sexual predators. So, you know, it again happens everywhere that we're thinking where we're working. We've had a suggestion about promoting prevent. Is that out there? Are we doing enough around prevent? And I think it's not just in terms of what the prevent agenda is, it's about radicalisation in general, and how people are vulnerable people are kind of pulled out of society and drawn to these kind of radicalists. The other area was promoting the safeguarding app, the NHS safeguarding app that was brought up. That can be downloaded on any of your devices from the App Store. It's free, so please use it, get it on there. Very informative, and it also has some CPD elements to that. I think the DBS presentation stirred a lot of queries. I think what's keen to be pulled out there is about the responsibility for referring people to DBS, and it is HR's, you know, and we need to do that, because I think Suzanne and myself and Helen and other people have been working on this sexual safety agenda where people have slipped through the net. We're getting there, but it's about us being vigilant and not only relying on the documentation, but being able to see what's going on around us. There was some discussion around feedback from referrals from the local authority. As you can imagine, there's hundreds of referrals that go through the front doors of the local authorities. Generally speaking, it's up to the referrer to find out what is going on with that referral. And I think that can be quite difficult, particularly from another question that came up in terms of how do we support our staff in making the referrals, and what is a good referral, and what can we do to improve that. What I would suggest is that you get in touch with your local safeguarding leads. There's training available from the safeguarding boards, and talk through some of the referrals so that it's clear what is good and what might require more information. what I would say is if there's not enough information on a referral, the local authorities will come back to the referrer and ask for that information. And I think that's sometimes a bit of a worry for people about acknowledging whether the referral's gone through. I've had a situation last week where I know of a case where there was at least 3 referrals went into a situation, but you know, at least we know that that referral's gone in. I suppose the other issue as well that's come up is about referring and requirements from CQC. What can they do? Some of the gaps in what CQC are able to do because of the regulations, and you know, all I think, and Helen and other colleagues have answered some of those questions. They're areas that we want to push and we want to improve on, and we want to get that recognition about how we can access non-regulated providers. And I think that more or less captures everything. I think what's key is not being worried about referring and thinking about your whistleblowing policies. Suzanne touched on that. Go back to your organisations and just double check what's in your whistleblowing policies. Another area was where we need to think and be kind to each other, be kind to our staff, be kind to people that are not displaying the usual behaviour. What could be going on behind closed doors in their lives? We're very good at punishing people, you know, for attendances and areas of like that in work, whereas there could be a lack of attendance due to domestic abuse or various other things. So let's be kind to each other and think about what's going on out there. Think about that professional curiosity. I think I've possibly captured everything that's kind of come up in the chat line. Helen alluded to us pulling those questions together and answers so that they'll all come out as a pack, which I would expect with the slides. Helen, I don't know whether you want to come in there in case I've missed anything.
I think you did an excellent summary. Thank you very much, Liz. And I suppose just from CQC's perspective, just to reiterate, there were a couple of queries in there about what we were doing about the unregistered providers and the event sector. And just to clarify, it is the Department of Health and Social Care that set the scope of registration for regulated activities, and currently it's the exemptions that they set that mean that particular delivery is out of scope. We have been lobbying for some time for that to be changed, and there is a consultation which has been deferred because of the pandemic, but is now due, I think, in the spring of 2022. So I would urge all of you to participate in that consultation if like us you believe it's appropriate for those providers to come into the scope of regulation and for there to be a level playing field in terms of overview and scrutiny. There were some questions about our internal analysis, and I have endeavoured to answer those in the chat, but I'm also happy to ensure that we put some more information in the questions document. I think that's probably everything, unless anybody wants to cover anything that is in there that hasn't been responded, we will pick up. So if you'd like to move on to the next slide for us. Do you want to go back to Liz? Because I think you wanted to run this one, didn't you? Or is this mine?
I think that's yours, Helen, I think.
Okay,
yeah.
Okay. So in terms of next steps, you can continue the conversation about this particular workshop by getting involved on our digital platform, and you can also sign up for your sector bulletin in the link there. So we provide a bulletin for all of the different sectors on a monthly basis, and some of you will have seen this sexual safety workshop promoted in that bulletin. We are also on Twitter, and you can join on CQC Connect as well to get more information. Would you like to go to the next slide, please? So finally, I'd just like to say thank you to all of you for joining today, mindful of the current pressures within the sector, and really appreciate your commitment to this particular subject. Please help us to improve by completing the evaluation, which was sent to you and has also been placed in the link on the chat. The recording of the event will be shared in the provider bulletin that I've just referenced at the end of this month. Any questions that we haven't addressed, and we'll try and summarise those that we have as well, will be in a document which will be available with the slide deck on request. So if you go to the provider bulletin, you'll have access to the presentation recorded, and it will direct you as to how to request the slide deck and the questions. And finally, I just want to say a huge thank you to all of our presenters today. It's been really, really helpful to have your contributions, and I know that there's been a lot of work that's gone into each and every one of those presentations and the liaison with us ahead of today. So thank you so much for your contribution. And finally, just a huge thank you to the fabulous team behind the scenes at CQC and at NHS England, who've worked very, very hard to facilitate this event, and we look forward to hearing what you thought about it. I hope you all have a very good week, and thanks again for your contributions today.
Thank you very much.
Thank you, everybody.
Thank you.
Thank you.